Now, the other thing that is going on is that if you look at the inflammatory attack, actually from the very beginning, there is an immune process in the blood that's migrating into the brain, participating in the attack of the brain. But there also are immune cells inside the blood-brain barrier that actually live there full time. They're called B lymphocytes. And they give us one of the pieces of evidence that we use to make the diagnosis early. And that's when we do a spinal tap and we look for what are called OCBs, or oligoclonal bands. Those are actually antibodies that are being produced by B lymphocytes that live inside the blood-brain barrier. And it turns out that pathology now suggests, come on in folks, don't worry about it, just come in. The pathology suggests that the B cells are actually the anchor for this disease. So they're producing antibodies in the brain. We don't know what these antibodies are targeted to, but probably one of the foremost authorities in this in the world is Jeff Bennett, who happens to be one of our colleagues in the program at the university. And his evidence right now is that they're targeting a group of molecules called gangliosides. And that's not important now, but I think it will be important in the future as we begin to identify biological markers of people who are going to do well versus people who are not going to do well that will help us deciding what therapies to use. But this immune system that actually resides inside the brain is actually present at the very beginning. It's not a late effect, despite some impressions to the contrary. And then there's also, the brain is shrinking. So I call this neurodegeneration. This is death of nerve cells. That's also present right at the very beginning, as I showed you in that previous slide. So all of these processes are going on, the inflammation leading to the damage to nerve cells. And in the early phase, we see the disease as relapses, but patients are stable in between, even though, in fact, their brain is shrinking and this attack is going on. And then, as you know, the typical pattern for relapsing forms of MS is that after a certain period of time, untreated, many patients, actually about 90%, will enter the secondary progressive phase of the disease. Now, that is a problem for us right now in the field, because that nomenclature, relapse remitting, secondary progressive, and then the third group, which is primary progressive, was actually developed based on a survey that they did on the internet. It actually came out of a meeting on an island many years ago, and then it was modified by a survey. It's not, in other words, it's not science, it's opinion. And at the time, it was our best opinion about how to group patients in order to increase the chances that if we did a study with a certain drug, we were likely to see a treatment effect if it was really there. The assumption being that the biology of the disease in relapse remitting in this phase of the disease is different from this phase of the disease. The evidence now says that that's not true, at least not from the immunology standpoint. So the immunology that's driving the disease doesn't really change. There's no good evidence that there's any fundamental change at this transition point. And so there's another possibility for why we begin to see the progressive phase of the disease, which I think is actually well supported by the data but not proven. And that is that this could represent the point where all that reserve neurological capacity, that cognitive reserve that I've been talking about, is now used up. And now that subclinical disease activity we see in MRI and also aging and deconditioning due to fatigue and other things now shows up as a steady loss of function over time. So remember, I want you to hear what I said there. There actually are more than one reasons why patients may lose function when they enter this phase. One is they have ongoing inflammation. But the other one is that because of the MS, they're less active. And we know as we're less active, we lose strength, we lose coordination, and in fact, we lose nerve cells. Nerve cells need to be fired at a certain rate to remain healthy. And so the point of that is that if you really want to change this trajectory here, you have to do more than just shut off the inflammatory attack. You also have to try to reverse or prevent those secondary changes that result from the MS. So we have to get people to exercise, eat healthy diets, be cognitively active, et cetera. And we have good studies showing that exercise actually improves function in this stage. Okay. Now, the other implication, could we go back just for one thing? The other implication of this is, again, no, thank you. The other implication of this model is that if you look at these MRI events, they have a certain probability that they will show up as a relapse. The probability is actually around 5 to 10%, depending on which data set you look at, but using higher strength MRIs, it's less than 5%. If you build a statistical model of 1,000 patients, and you give them all the same number of new MRI events per year, and you give each MRI event a 5% chance of manifesting as a relapse. So in other words, you're flipping a penny, and each flip is independent of the previous one. And you just let the model run, it turns out about 10 to 15% of those patients will not have had a relapse within 10 to 20 years of onset of their disease. So that suggests that this PPMS, the primary progressive MS patients, might be those pennies that just never landed on heads and they never got a relapse early on, just a matter of luck. That's actually consistent now with the MRI and the immunology data. So the reason I'm mentioning this is that I think we've done patients with MS an injustice. Because of this nomenclature, the FDA assumes that neurologists know what they're talking about. And so they require us, if we want to get a drug approved for relapse remitting, secondary progressive, and primary progressive, we have to do 3 separate studies. We have to do a study with patients with relapsing form, patients with secondary progressive form, and patients with primary progressive form. A phase 3 trial in this area costs around $100 million or more. So the problem with that from a business perspective is that most companies will focus on this group because that's the largest group. In fact, those are the ones that mostly have private health insurance, whereas patients in this group are often now on disability and Medicare. And so this is the group that we've developed most of the therapies for. But the data is emerging that these are not really fundamentally different diseases. And if you allow for the aging effect, in fact, the same therapies that work here can work here with the caveat. And the caveat is our ability to detect treatment effect in this phase, if we're looking at disability only, is actually much more insensitive than looking at relapse rate and MRI disease activity back here. And it's just a matter of the technology. We don't have very good ways to measure gradual changes over time. We can count relapses and we can count gadolinium-enhanced lesions on MRI. And so as a result, it's not uncommon for patients with primary progressive MS not to receive immunological therapy based on this old perception that that might be a biologically distinct group, even though at this point the evidence suggests that that's not the case. And that's particularly true for people with primary progressive MS that are less than age 55. So in other words, if we treat the primary progressive patients in early phase of the disease, such as with rituximab, which we've done, it has a good effect. But if we wait for patients to hit age 55, whether they're relapsing form or primary progressive form, it's very hard to show any treatment effect in that patient population. And again, that matches the biology as we now know it. And the next slide. So in order to maximize function in MS, it's not sufficient just to use immunological therapies. Diet is important, and I'm not going to spend a lot of time on it now, but you can ask questions about it. The reason that it's important is not so much that MS is a dietary disease, because the evidence is outside of vitamin D, it's not. And vitamin D is not primarily a dietary issue. But if you develop any other diet-related diseases, obesity, hypercholesterolemia, hypertension, diabetes, that will increase the probability of disability. In fact, the relative risk of disability if you have diabetes in MS is 2.5 times greater than it is for patients who don't have diabetes. Even if you just have elevated cholesterol, your risk is about 1.4 times greater for disability than it is for people who don't have that. So in other words, if you develop other illnesses, other comorbidities, that can increase the risk of MS disability. In addition, as we've talked about, we also want to maximize recovery of function. And there tends to be a focus on therapies that repair the nervous system that are in development. But in fact, exercise and intellectual activity are already available, and we already have evidence that that can improve function, mostly through that cortical remodeling. And in addition, as I mentioned, the cognitive reserve is partly genetic and partly environmental. The environmental factor is how active you've been, how much education you've got, how physically active you are. Both physical activity and cognitive activity both have similar benefits. So you can either run or you can do actually search the internet. Either one of those actually will increase your cognitive reserve. So immunological therapy, which is my primary area of focus just in my career, that's where I spend most of my time, is the area we've had the most rapid advancement in recent years. But this area is moving along pretty rapidly, and I expect reparative therapies to be emerging over the next several years. Give me next time. This is a list of some of the newer therapies. I'm not listing interferon and glutamer acetate just because we've had those for more than a decade, and I assume most of you know about them, but I'm happy to talk about them. Natalizumab I'm not going to talk much about, but it is a very highly effective therapy. The key issue with that is progressive multifocal leukoencephalopathy. Rituximab, as Karen mentioned, we have had phase 2 and phase 3 trials on this that do show groups that respond to this very nicely, but because it's an old drug that becomes generic soon, it's not going to be developed by the company for FDA approval because they have to invest close to $1 billion to do that. So instead, they've developed a copycat drug called ocrelizumab, which has completed phase 2, and it was reported that it had an 80% reduction in relapse rate and about a 60% reduction in disability progression. That's actually better than Tysabri, which is the best therapy we have right now. And the safety profile over the 2-year follow-up was actually very, very good. So that drug's about 4 or 5 years away from approval, but it's not that rituximab is not a good therapy, it's that it's not profitable for a company, which is the reason it didn't go to the FDA. So that's why we were working with the state legislature to try to establish a process for off-label use of drugs that actually have class 1 and class 2 evidence for benefit. So we have lots of scientific evidence that the FDA does not consider, and that's the FDA's issue. Cladribine was denied approval by the FDA. Fingolimod, now called Gilenya, was approved, and I'll show you a little bit of data on that. Alemtuzumab is likely to be approved in a year or two. Teriflunomide probably goes to the FDA this next year. PG12 and laquinimod are likely to go to the FDA late this year, early next year. And these two drugs have had recent press releases and one scientific report that makes them extremely interesting. These are drugs that do not suppress the immune system. Instead, they seem to be neuroprotective in their mechanism of action. They work in the brain. So they're not associated with increased risk of infections or cancer, as far as we can tell, with one exception here. And their safety profile is actually quite good. And so this drug reported in the Boston Globe, a major scientific publication, that it had a 58% reduction in relapse rate. So we've not seen the rest of the data, but that's remarkable. Fingolimod, the first oral agent to be approved, has a 55% reduction in relapse rate. Natalizumab is around a 60% reduction in relapse rate. Laquinimod only had a 27% reduction in relapse rate, but it had remarkable effects on preserving brain volume and preventing disability. So again, it suggests that it's separating the inflammatory process from the consequent neurological injury. And this drug has an extremely good safety profile. There's almost no side effects of that drug. It's a once-a-day pill. And then I'm not going to talk about daclizumab. It's a little bit farther off. Okay, on the next slide.